Hi, I'm Dr. Mark Feinberg of UB Orthopedics and Sports Medicine. I put this video together to help you better understand shoulder instability. The shoulder is a complex ball and socket joint. It is the most mobile joint in the body. It is this great mobility that makes the shoulder prone to injury. A frequent analogy is to compare the shoulder or glenohumeral joint to a golf ball on a tee. Placed on its side, the ball will simply fall off the tee. To maintain its stability, the shoulder relies on a sophisticated balance of soft tissue restraints. The main stabilizers of the shoulder are the labrum and the capsule. The labrum is a ring of cartilage around the socket, or glenoid. Centrally, it is continuous with the smooth or articular cartilage, and peripherally with the joint capsule. The labrum acts like a bumper and increases the ball and socket contact area. The labrum also anchors the capsule, which is a thin layer of cloth-like tissue which is normally just loose enough to allow for a large degree of motion, but tight enough to resist instability. Shoulder instability and dislocation occur when the shoulder capsule is stretched or torn, and/or when the labrum is detached from the glenoid. Shoulder dislocation can occur when a reaching arm is forced backward, as in making a tackle or battling for a rebound. Patients less than 20 years old at the initial dislocation have up to a 90% chance of recurrence. A comprehensive shoulder examination will assess the direction and degree of looseness in the shoulder. Drawer tests, as seen here, and positions of apprehension can help support the diagnosis of shoulder instability. X-rays are usually performed to assess alignment and look for fractures or any bone loss. MRIs are often performed to evaluate the soft tissues, looking for tears in the labrum or capsule, as well as checking out the rotator cuff. Surgery may be considered if shoulder pain and instability compromises patient comfort or function in spite of a reasonable trial of strengthening exercises. If a tear of the labrum is identified, this can be repaired with surgery. While open repairs for shoulder instability are still needed for cases with large bony defects and capsular deficiencies, arthroscopic repair is now the standard of care for the majority of shoulder instability cases. Small incisions or portals are made around the joint. The scope and surgical instruments will go into these incisions. The scope is inserted into the back of the shoulder joint. Saline solution flows through a tube or cannula and into the shoulder capsule to expand the joint and to improve visualization. The image is sent to a video monitor where the surgeon can see inside the joint. A probe is inserted to help fully assess the extent of the labral tear. The frayed part of the labrum can cause pain and irritation in the shoulder. A surgical instrument called a shaver blade is inserted into the joint and the damaged tissue is removed. Other surgical instruments will be used to reattach the labrum to the glenoid socket using suture anchor devices. Anchors are inserted into the bone, sutures attached to the anchors are passed through the labrum, and the sutures are tied down. Here you see the steps involved with a knotless anchor repair. The suture has been passed around the labrum and a drill hole has been placed in the bone. The sutures are passed through the eyelet and the anchor is passed into the joint. The anchor is then impacted into the bone. The anchor inserter is then removed, and the suture is cut, completing the labral repair. This type of injury is also associated with a stretched or torn capsule. The injured capsule can be folded on itself and sutured together using free suture, thus tightening the capsule. After the repair is complete, the surgical instruments are removed and the procedure is complete. A repair requires approximately 6 weeks of protection in an immobilizer. Early gentle motion exercises are often initiated to prevent stiffness and loss of motion. It often takes 6 months to allow for complete healing and rehabilitation prior to returning to strenuous activities. A motivated patient who undergoes arthroscopic surgery and complies with a well-structured rehabilitation program can expect a very high rate of success. Thank you for allowing me to share this important information regarding shoulder instability.